So today, the chief complaint is a 28-year-old woman that's coming in with headaches every time she coughs. She says that these headaches started about a year ago, and she notices that every time she coughs, she sneezes, she laughs, or even if she just strains really hard when she's trying to use the bathroom, she gets a really severe headache. She says that it's about an 8 out of 10, with 10 being the worst headache that she's ever experienced. She describes it as stabbing and really sharp, and she says that it lasts for about 5 minutes and then goes away as soon as the activity that she's doing has stopped. So she says that for these headaches, they're localized to the back of her head on both sides. And they aren't very positional. They don't get better or worse if she's standing or lying down, but she does say if she bends over or has any really straining activities, she does get worse headaches. So for these types of headaches, I'm thinking to myself, these sound like headaches that are getting worse with Valsalva maneuvers or episodes in which she's having increased intracranial pressure. And whenever I think about headaches that are getting worse because we're worried about increased pressure in the brain, I'm worried about something being in the brain that shouldn't be there. Whether that's blood in the brain, which is something we need to catch right away to make sure that she doesn't die, or it could be a tumor or a mass. So I really need to know more information to really figure out what's going on. In addition to these headaches, she says that she's having some blurry vision or some double vision sometimes. It comes and it goes. And she's started to notice that she's a little unsteady on her feet. She wobbles a little bit when she walks. She's a little off balance when she's on her feet, when she's walking. So not only am I worried that there could be something in the brain, some blood or mass in the brain that's causing these headaches, or I'm worried about something that's going on in the brain that's attacking the white matter. The white matter are the connections that we have in the brain to have different regions of the brain communicate with each other. And sometimes you can have an autoimmune process that's attacking itself. So your body's attacking itself, in this case, the white matter, and you can have these transient neurologic deficits. When we say transient neurologic deficits, what we're saying is that there is a neural deficit or a problem, but it's transient. So it comes and then it goes. So right now I'm worried about her headaches. I'm worried that maybe this could be something in the brain like blood or a mass, or it could be her body attacking itself, causing these symptoms to come and go. So when I ask her more questions about her past medical history, she says that she does have depression. She's on an SSRI for that. She says that in terms of family history, her mom does have migraines. So when these headaches first started, she thought that maybe these could be migraines. She says that she is a school teacher. She teaches the 2nd grade. She doesn't smoke. She drinks occasionally, doesn't endorse using any recreational drugs. So right now, based on her history and what she's told me so far, the things I really need to rule out and focus on my exam is there anything that could tell me that there's something big or scary going on in the brain? Is there blood in the brain? Is there a mass in the brain? Or is her body attacking herself to cause these symptoms? Overall, she has normal vital signs. They're all within normal limits. She is well appearing. She doesn't look like she's in any distress. For her mental status, she's awake, she's alert, she's engaged. She doesn't have any deficits for her mental status. What's really interesting is when I get to the cranial nerves. When I ask her to have eye movements, one thing I'm looking for are her eyes going one side to the other, up and down, and I see a few things that catch my attention. The first one is that when I ask her to go from side to side, she can't bury her sclera all the way. In other words, when she moves the dark part of her eye all the way to one side, I still see a little bit of the white part, the sclera, meaning that she's not quite able to abduct in both directions. So that tells me that there's something going on with her cranial nerve 6. And when we think about the cranial nerve 6, it comes out of the brainstem area. And so maybe her symptoms are occurring because of a lesion in that area of the brain. The other thing that I notice when I'm asking her to do her eye movements is that when I ask her to go up, she's able to go up. But then when she goes down, her eyes rapidly go up and then back down. That is called downbeating nystagmus. That actually also tells me that this area of the brain down here might be affected, because when we see downbeating nystagmus, usually that means that there's a lesion in the area of the brain or the skull that is right where the base of the skull connects with the top of the spinal cord. So this exam is helping me understand where in the brain this could be occurring. If it's a brain bleed, it could be happening in the back part of her brain. It could be expanding, and within hours she could die. It could also be her body attacking itself in that area, attacking the cranial nerves. And if it continues to attack the cranial nerves, she'll continue to lose function. That could lead to blindness or even paralysis, where she's not able to move. So I need to continue my exam. Actually, her motor strength is completely intact. She's strong throughout. When I do the sensory exam, I'm also paying a lot of attention to the sensory exam because one of the things I mentioned is that I'm worried about multiple sclerosis or a demyelinating disease. And when you see that, usually there's also changes in sensation. I do a very thorough sensation exam. First, I just do light touch. Is she able to feel me on both sides of her body? But then I also test for vibration. So this is a really fun exam where we actually use a tuning fork and we're able to induce a vibration and we can see if she's able to feel it on the tips of her fingers. Her vibration sensation is intact, and then I also do proprioception, which essentially is having her close her eyes, and then I move her thumb or her big toe up and down and ask her which way is it moving. Her proprioception is also intact. But overall on her sensory exam, something that catches my attention is that she keeps telling me that her fingertips on both hands just feel numb. They just feel different than the rest of her body. Her coordination's intact, finger, nose, fingers intact. And then when I ask her to walk, she does have a slight wide base gait, which is what we call ataxia. It's a little bit unsteady, a little bit unbalanced. And when I ask her to put one foot in front of the other for a tandem gait, that's also abnormal. She's not able to do that. So overall, this clinical picture is still telling me that there could be some type of lesion or mass. When I'm thinking about localization or where this could be happening in the brain, her exam is telling me that this could be in the posterior fossa region or the posterior region of the brain. And the reason I'm thinking about that is because on her exam, she has an unsteady gait. And for ataxia, we really think about the cerebellum. I also noticed that her cranial nerve 6 were abnormal. She wasn't able to abduct on either side. So that can mean that the brainstem area is affected. But what's really cool about the cranial nerve, especially cranial nerve 6, is that it can be a false localization sign. Essentially what that means is that yes, it could be at the origin of the cranial nerve 6 or in the brainstem area, but cranial nerve 6 is a fun nerve because it has a very long course along the skull, and it can be so essentially if there's any increased pressure anywhere along that course, it could cause abnormal abduction of the eyes. So it could be where it originates from, or it could be anywhere along its course to help with that movement in general. So we are really worried that there could be some type of lesion or blood in the posterior part of her brain. And then we're also worried that this could still be her body attacking herself, a demyelinating lesion. When we are thinking about differential diagnosis for her, in addition to it being a brain bleed, we are also worried that could this be a tumor or a lesion that's happening in the back part of her brain. We're also worried that could this be an autoimmune process, her body attacking itself. These headaches that she's having, it could also be an upsetting of a clot. She could have a clot in her vessels that's causing her to have these symptoms as well. So the things that I need to do now, right away when she comes in, is get a CAT scan. I want to get a CAT scan right away because I want to make sure that there isn't blood in the brain. And if there is blood in the brain, she needs to go to surgery right away. We get the CAT scan and it's normal. There's no blood in the brain, which is great. The thing about a CAT scan that makes it great is that it's really fast and it lets us know right away, is there any new blood that we need to act on? But a CAT scan isn't that sensitive. What that means is that it doesn't give me information about specific details in the brain. If I'm worried about demyelination or the body attacking itself, I need an MRI to look at the white matter in the brain. And if I'm also worried that there could be a mass or a lesion, especially in the back part of the brain, the CAT scan actually doesn't give me a lot of view for the backside of the brain, so I also need an MRI to get more information about the back part of her brain. And when we get the MRI, what we see is that the back part of her brain, specifically the cerebellar tonsils, has started to herniate outside of the skull. She has a Chiari-1 malformation, and that actually explains all of her symptoms. For a Chiari-1 malformation, you do see increased headaches in the back part of the head when you have Valsalva maneuvers or when you have things that increase pressure in the brain, whether that's laughing, coughing, sneezing, or even straining too hard. And that's what she was explaining to us. Not only that, but then when you start to have that herniation down of the cerebellum, it can affect that junction area, and that's why we saw that downbeating nystagmus and the cranial nerve 6, and she wasn't able to abduct her eyes all the way to one side. Her Chiari-1 malformation was pretty severe. Her tonsil herniation was about 8 millimeters, which is above what we would expect in someone her age, and she was having symptoms from it. Not only was she having headaches, but she was having tingling in the finger areas, and I was starting to see deficits in her cranial nerve, specifically cranial nerve 6. So she needs to go to surgery or her deficits could become permanent. She already mentioned that she's not able to walk as well. She's unsteady on her feet. These deficits could become so severe that she couldn't walk at all. It also could be that even though right now we're only experiencing the tingling of the fingertips, it could even lead to sensation loss and paralysis of her arms, where she's not able to move her arms. So overall, we need to get her to surgery so we can make sure that these do not progress and get worse and become permanent. She went for surgery, and 6 months later, she is doing better. She's no longer having headaches after she coughs or she sneezes or laughs, and her balance issues are still there, but they're better than they were before.